you truly want to differentiate yourself, learn TMJ, do it well, get people better. And most of those people, when you're finished, need orthodontics.
Right.
So you still get to do orthodontics, which you love.
Hey there, everybody. It's me, Dr. Glenn Krieger, today with our two-time returning champion, Uncle Ron himself, as he likes to be called, Dr. Ron Roncone. Welcome.
Thank you, Glenn. It's a pleasure to be here. I guess we got tired and we're not roasting weenies, at least right now. Maybe a little bit later. We're going wine tasting. Nobody
has any idea what we're referring to, but we are recording this on Memorial Day, when we could be roasting hot dogs instead of sitting. But we're the kind of guys who, we don't care what day of the week it is. We'll take care of this. And I'm making ribs for my family for later anyway. So
that's what we're doing.
And again, to be clear for everybody out there, the first lesson you're going to learn is that it's not Roncone. All right, like a lot of people changed their names to when they came to the United States many years ago. It is not Roncone, right? Because it is an Italian name. It is Roncone.
Roncone.
There you go.
Sì. Molto bene.
Grazie. Prego. So we're going to do this entire thing in Italian, okay?
There we go.
I've been watching The Godfather.
With me would be Sicilian, but that's another story.
Yeah. So you may all recall that we've had Ron here before. I've had the pleasure, as part of our Orthopreneurs RD group, I think about 70 of us came to see him in San Diego. It was literally, not figuratively, it was like literally the last thing that anybody did in that group before COVID hit. It was like February of 2020, right?
Exactly.
It was literally, I remember getting on the plane, coming back, and like a week later, everything was shut down. But it was one of the greatest courses any of us has ever taken. It was beautiful in San Diego, overlooking the bay there and the ships. It was beautiful. But for anybody who knows anything about Dr. Roncone, you know that he is a master of systems and policies, efficiencies, which kind of interesting to me. I want to talk a little bit about that. It's a new buzzword back in orthodontics, is efficiency, right? But you've been talking about efficiency for decades. And I really want to devote a significant portion of our conversation today to the clinical side of ortho related to TMD, occlusion, and we can jump into that a little bit. But for those who may not know anything about you, for those of you who may not have been able to listen to you speak, do you mind taking maybe 90 seconds and give them a little bit of a story about your background and how you ended up becoming an orthodontist and how you ended up to where you are now?
It could be a 4-hour story, but I wanted to go to, I wanted to be a neurologist or a neurosurgeon. My dentist, who was just superb, talked me out of it and said, go into dentistry. You build in dentistry. And he is a superb restorative dentist. I literally flipped a coin. Dental school won, and I went to dental school instead of medical school, and I began to regret it. Long story, I stayed in dental school. I loved Crown and Bridge so much that I thought this would be great to go into restorative. Then I realized that I would be somebody like me, who actually was a lab tech. I did work for the head of Crown and Bridge department, and if I went into Crown and Bridge, I wouldn't be doing any of the building of bridges, which I like. So I went into orthodontics. In dental school, I was in dental school and medical school, and because of who my mentors were, I had to learn a lot about muscle physiology and neuroanatomy. Not what I really wanted to do. When I got out, I went to Harvard, did my residency, taught there for a while, then taught at University of Maryland. Came out to California. Being an Eastern boy, most of us went to Florida if you wanted warm water, but I hated humidity and I'm allergic to mosquitoes. Found myself in San Diego, and through lots of happenstance, I began having lots of adults and treating lots of TMD. And sort of like now, nobody wanted to treat it. And I just thought it was really cool. Yeah. And
I always say how much I love treating adults and unwinding the whole TMD problem whenever possible. But anyway, sorry, I was waving at him if you're listening to this.
Yeah, I know. And it's I tried starting a TMD study club in 1979, and everybody said, and I don't do TMD. I don't ever see TMD. Within about 2 years, we had 50 people, general dentists, oral surgeons. in a study club that was really good. But then the specialists started hitting on the non-specialists for referrals. And then the three of us who started said, we'll just have our own little group. We'll refer to each other. We'll, lean on each other when we need help. So as it turned out, my practice has never been under 50% adult. Over the last three to 4 years, it's like, I think 82% of every new patient exam we get now is an adult, almost always TMD.
Right.
So it's really changed.
Yeah. And am I crazy for thinking you had some medical acceptance at some point?
Yes.
Acceptance to medical school, I think.
Yeah. As a matter of fact, I spent simultaneously spent 2 years in medical school. I did my physiology, etc., in medical school, not dental school, when I was at Marquette University.
It's amazing. It's amazing. And I think when we did Two Truths and a Lie or something, I think, do you have like bold the perfect 300 using? I remember you pitched like some number of perfect games, bold perfect games, and something to do with like your left and your right hands.
Yeah, I was a baseball freak and a bowling freak when I was a little kid. My brother had been had a major league offer, and so it's too long a story. But you said, "Is there anything unusual?" And I said, "My guess is you probably have not had anyone who has bowled multiple 300 games, has pitched no hitters, both right and left-handed." And has had multiple holes in one, all while being really pretty average.
Right,
so,
all by age 37.
Yeah. All of those were by 17 or 18. Unfortunately,
we joke that if you're looking right now, we always joke that Dr. Roncone is 37 years old, that he doesn't sleep much, and this is the impact it's had on him, is what he says.
There you go.
So great. Let's dive into a few things real quickly. As you heard me say, I've only been in ortho myself for 7.5 years, but I've been in, this month marks 30 years since I graduated dental school. And you work long enough, you hear certain buzzwords come through the industry, right? You hear extraction, non-extraction, TMD, vulnerability, efficiency, and they cycle. They go back through multiple times. Airway, which I think is more here to stay. I don't think that's disappearing, but efficiency is certainly the big buzzword right now. And as I mentioned, you've talked about this for years. What are some, if I was a resident listening right now, or new grad, or even somebody like myself out 7, 8, 9, 10 years, what would be a few tips you'd give me or them related to efficiency and the role it should play in your practice? Like, how big of a role should it play? And what are some good tips for really getting there?
I think the two words that I think have to come together, being efficient and being effective, need to go side by side. If you want to finish a class 2 case and make it into a class 1 and you get it there, and based on whatever your nathological or occlusal principles are, you reach those, you are effective. Now, being efficient is getting there with the fewest amount of appointments and the shortest appointment times, with the fewest number of appointments within the shortest amount of months, all of which the patient would want to have. So getting both of them, you can be efficient, be finished in 11 or 12 or 13 months and not be effective. You still be a full cusp class 2, the teeth look straight. So attempting to be effective to get whatever your goals are, and getting there efficiently, I think those are keys.
Every time you answer something, I have 30 questions in my head I want to ask you. One of them was when you talked about effectiveness, if you can get there. This is sort of a loaded question, but those are my favorite kind. Do you have cases, again, this is for me personally asking you, nobody else is listening, it's just me. Do you have cases that come in adults in particular, where they're class 2 and you just say, it's not on our treatment plan to make you class 1. We're going to get you straight teeth, do the best we can, but we're not going to make you class 1. Is that something that you sort of give your dispensation to me if I have a patient come in and I want to do that? Or because of your nathologic TMJ background, are you much more, shall we say, locked in, fastidious to the idea that we must finish them class one?
If you had asked me that question 25 years ago, I would have said it's class one, my way or the highway, blah, blah, blah. And there was a dentist who was in the same building as I was for many, many years. He referred well over 100 starts per year.
Wow.
And one day, this patient came in, and she had sort of a class 2 division 2. She was her daughter was getting married in less than a year. She said, I am just always embarrassed of my teeth. Can you just straighten my front teeth? And I first said no. And then I just saw tears coming down her eyes. And I said, okay, you realize that your overjet, which you think is an overbite, is going to get significantly worse because your 2 incisors are back. And she said, I don't care. I just want to look good. So, it didn't take any time at all to align her front teeth. She looked good. The class 2 looked worse. And I wrote a 3-page letter to the dentist down below, just telling him I apologize, blah, blah, blah. And, we almost never met in the parking lot, but this one night we met and said, how you doing, Larry? How you doing, Ron? And he said, what the hell was that 3-page letter you sent me? I said, well, she just wanted her teeth straightened for her daughter's birthday. And that just isn't what I do, but I did it and I wanted to apologize. And he laughed. He said, you orthodontists are all sick. He said, you think you can be perfect with everybody. Now, this is far enough away long ago. He said, if you're a general dentist, you compromise all the time. I want a crown and they want a filling. I want a fixed bridge and they want a partial. So if I give them a partial, are they better than leaving the space? Absolutely. If I put in a filling and it's a big amalgam, is it better than putting in a crown or doing nothing and losing the tooth? Yes. And he said, so you just think you can fix everything. But it still took a few more years to say, if they come in, and no, that's not my goal. Finishing class 2 is not my goal. Based on the circumstances, I would do that. That would mean I'd probably have to do a full occlusal equilibration, then maybe restorative or whatever. But years ago, I would never do that. A friend of mine once said, don't tell anybody you finish anyone class 2. He said, how many cases? I said, I don't know, 1, maybe 2 a year. All adults said, nobody wants to hear that. And so I said, okay, they'll think you don't do anything class 1. But it was a loaded question, and there are a couple people a year I will. I mean, those are equilibrations. You got to give them something to rely on. But yeah, depending on the circumstance, and if you treat a lot of TMD with sick joints, trying to get more than 2 teeth to meet sometimes is a challenge, especially if they won't do surgery, etc. I don't leave them out there anymore and say, just, go to somebody else. And if they're in pain, I get them out of pain and give them the best occlusion I can.
Nice. So you mentioned the 3 letters. You said TMD. So let's dive into that a little bit. I'm going to ask you, talk a little bit about, because you and I spoke a little bit before we started recording this. We didn't get into a lot of detail on stuff, but we both have a love of occlusion, gnethology, as an understanding of where we start from. And we'll dive into that a little bit more. But it's really interesting to me that when I left restorative, where I was doing full mouth reconstructions and had to use centric relation, that's the whole purpose, right? What's the purpose of centric relation? A repeatable starting point. So when I would do dentures or I would do a full mouth reconstruction, I had to use CR, which is why I spent 400 hours at the University of Washington in a special program of gnethology. And my teacher, Jerry Schultz, may he rest in peace, worked at a lab bench right next to P.K. Thomas. And I'll tell you, brother, we did a lot of wax ups. We did a lot of equilibrations. We did a lot of tattooing of the hinge axis. We did Stewart, fully adjustable, articulator. And I know you have a background in that too. And then I came to Ortho, where I started talking about my gnethology background, and I was a pariah. You could see, already I was a non-traditional candidate. I wasn't a number 1 choice. I knew that already. And the moment I opened my mouth and started, they'd ask me, tell me about gnethology and your thoughts on it. Oh my God, it's amazing. And I once posted in another group about an articulator. And the responses were what I would call so uneducatedly emotional. that I just sort of drop the conversation. I've heard people quoting famous people saying an articulator is a great representation of some. I don't know. It was something silly.
Yeah, and nathology is the
Right.
science of how articulators
Right.
chew.
That was
Yes.
it. Someone quoted that one, and
Yes.
you said it ago. That is like, and it's quoted by a very famous, I don't want to mention name, person in orthodontics.
Very
It's
famous.
arguably one of the most stupid comments I've ever heard, because anybody who's ever, it's kind of funny, and I'd love your feedback on this one question before we dive into TMD. I'm new to this field, right? 7.5 years. I would not tell you I'm a master. I would not tell you I've been around to see everything in ortho. But it seems to me the most polarizing statements, the most polarizing arguments are made by those who have the least amount of time invested in the thing they're talking about. You never hear anybody who's used CBCTs or tomograms for a decade say, oh, I think they're a waste of time. You never hear anybody who makes a ton of splints tell you, I think splints are really overused. You never meet anybody who does tons of airway in kids who actually has a track record of helping them go, I think this whole airway thing is nonsense. They'll tell you specifically what is nonsense, but it seems like the most vocal opponents to anything are the ones who know the least. Is that your experience? Have you found that? Or are there legitimately arguments where we've learned better through our experience and have come out and said, you know what? Doing this has been wrong. We shouldn't have been doing this.
I think a lot of it depends on where and when you went to school. With all of that background, when I got into my residency, not one person ever said centric relation. Not one person ever said hinge. Not one, and I'm talking about my guys in the program, and not one of my teachers. Not one of the people I was taught over the years ever mentioned it's, we need to get somebody in the hinge. And the background is that there have been reasons why I think some people are reticent to talk about centric relation. Just under the first 5,000 patients I treated to centric relation. Centric relation in those days was in the RUM position, the rearmost, uppermost, midmost. Yeah. After those 5,000 cases, one of my mentors and several other people decided, no, you can't do the rearmost. It's going to be uppermost, midmost.
Yeah, good luck finding that one, by the way.
Yeah. And you must have, with all due respect, because I followed and tried doing that for 25 years. You needed to have a special kind of a bite, a power bite, a Dawson bite, a Roth bite, in order to do that, manipulate the jaw to where you want it. Since then, I never told anybody where I thought centric was. I found centric. Yeah. And as centric is what I call when you can get the patient in SOC, the sound of centric. Get the mandible, and whether it's on a splint, and when you're all finished, get the mandible and just whack it together over and over again. That patient will not stop you. And if the patient doesn't tire and start moving their head, that is centric relation.
Repeatable.
And it's repeatable. Yeah. And so if it's not, you try to force somebody somewhere, and there's no other joint in the body that you said you must manipulate the joint. And I manipulated it for a long, long time,
and
not knowing any better.
If I can interrupt for a second, I'd ask you to tell me what other joint in the body has both translation and rotation, right?
Yeah, for sure.
That's what screws up everything. And the interesting thing about it is, all I'm looking for is a repeatable position, right? And like, here's something, and we'll dive into this more, but I told, Uncle Ron, before we started this conversation, I said to him, this is going to be like we both have a beer or a wine or a drink in our hand, and we're just going to be talking pathology. Because when you get two people around who love occlusion, like, nobody wants to talk to us about this stuff. Nobody. Yeah. But the interesting thing is, like, here's a word that we never hear in ortho, which I think is one of our most valuable tools, deprogrammer. Right?
Yeah.
Like to deprogram, like, why in ortho? Now, there are some ortho programs out there, to their credit, that do talk a little bit about TMD. I know of a couple, but like, why shouldn't every orthodontist learn how to make a deprogrammer in literally 3 minutes, 5 minutes, so that you can send somebody home with it, or even let them sit in I've had new patients sit in my chair while I deprogram them for, like, I'll take a slow speed suction and just have them gently, come forward, come back, like an old McHorris or somebody like that, and just have them sit on it for 5 minutes, 10 minutes. They'll tell you they feel their masseters releasing, they feel, the temporalis starting to lose, and all of a sudden, that end-on class 2 that you thought you were going to treat in the adult is no longer end-on. Now it's further back, and now you're like, okay, now I know. But why don't ortho programs talk about deprogramming?
Well, I think as soon as you get away, I think you mentioned, and I can't remember whether it was a little primer we did before we started this portion or at the beginning of this, if you're in dental school and you're going to do crowns and bridges, you do it on an articulator. If
Right.
you're going to be restorative, you put it on an articulator. Why is it not the same when you're going to be messing with the occlusion in some way? Do you not want to say, okay, where is the starting point? And I'm not saying everybody has to use articulators. All I'm saying is that why do we say it? You can put the condyle anywhere on the joint and just put anywhere on the eminence. It's no big deal. We get into the things, is loading the joint or unloading the joint good or bad? You've got people on either side. I am so against loading the joint because I get so many people who have come in here with sleep appliances, upper and lower hinged, and the eminence is totally flat. And it wasn't that way before. And so that brings me to, I know something I would be in an absolute small minority to say is, I don't believe in class 2 devices. I've lost 95% of the people who thought they wanted to listen to this when I say that. Only because of experience, and only because, in 78, because of a rickets course, I started taking tomograms, which he called laminograms, on every patient. To the same extent, you mentioned cone beam, and I'll lose a lot more people here, so we may have 5 people who even go to the end. But I tell people,
but we talk CBCTs all the time.
That's right. As I tell people who come to the course, it's okay if you don't like what I say. I don't care. I'm old enough to say I don't care. I wish you would like what I'm saying, but if you don't, it's okay.
By the way, I used to know a periodontist who knew literature in perio better than anybody I'd ever met. He was that guy you had drinks with and you go, hey, is there any literature on X? He'd go, yeah, so-and-so, 1974, this journal. Yeah. Plus, he'd always say, look, you have the right to disagree with me, but you'd be wrong.
Exactly.
I was like, that's pretty blunt, but he was right.
I start some of my lectures off, especially TMJ, but when I do the mechanics portion, a quote from Steiner, when he wrote, and I think it was published in 53, Orthodontics are cephalometrics for you and me. And he quotes and says, most of his colleagues do not believe in cephalometrics because they think it's a research tool, or it's too expensive, or you don't get there, even though there were people who were very famous who were using it. And I say, that is the cone beam. Because, and I'll see things, and again, I'll offend some people. They say, show me the ceph. Okay, I can show you the ceph. But when I see a lot of the cases shown and a lot of the Facebook blogs and things, you'll see a lateral ceph, and you'll see that the mandible, the lower half, the body of the mandible, and or the ramus don't line up. What was I taught in ortho school? You go and you take the median of that, right? If one body is higher than the other, you just go in between, and that's the median. And I've always thought, isn't anybody interested in knowing why there's an asymmetry? You can't know that unless you also look at the front.
Well, part of it, they'd always argue was radiographic. Like my master's was on this. They'd always argue that there was some sort of difference because of projection of a lateral ceph, that you were never going to have two sides that line up perfectly, right?
Sure. Yeah. And so you can say whatever you want, but then if you turn it around, and again, from a rickets thing, take a frontal ceph.
Right.
And you take a look. And so after doing that, we've been doing that since 78. And when you take a frontal ceph, my experience, it doesn't have to be anybody else's. There's no scientific, real scientific evidence. 78% of everybody who comes into, I take a frontal cephalon, and that's pretty much everybody, has a maxillary asymmetry, a cranial base or a maxillary asymmetry.
78%?
78%. And that's over probably almost 35,000 cases since 1978.
All right, orthodontists. Right now, inflation's high. We're not really sure what the future holds. The economy is certainly trending in a downward direction. And I'm just telling you, if you want to get together and reduce your concerns, learn how to navigate these choppy waters, be among friends, have great food, great learning, the Orthopreneur Summit is the only place you got to go. So go to opsummit2022.com. As I tell everybody, if it is not the best ortho meeting you've ever been to in your life, all you got to do is tell me. I will pay for your limousine back to the airport. I will pay for your flight home. And I guarantee you'll never take me up on that, because this is the meeting that's going to help you get the confidence to work through what we're going through now. And it's going to send you back energized and ready to go with your team. All right. So go to opsummit2022.com. Sign up now. We know you want to. Anybody out there who's never learned anything from Dr. Roncone, who's never sat through his courses, this is a man who is seriously committed to documentation. So again, this is not like me 7 years out of school saying, I kind of feel like there's an issue here. This is a guy who's going to give you statistics and numbers. So anyway, sorry for interrupting. I wanted to throw that in there.
No, thank you very much for saying that. And then you take a look and you say, well, because of rickets again, he took joint films. I don't know on how many, but he took joint films. Well, I got a quinsectograph in 1979, took joint films. So took joint films, took a look at each. And the interesting thing was that, huge portion of the time, there was degenerative joint disease. One joint was bigger than the other. And sometimes looking at the lateral joint film, you said, that looks pretty good. But if you look at the coronal cut, then you say, oh my God, one is so much smaller than the other.
Right.
You can't see that on a Panorex and a lateral ceph. So when somebody said, well, we take a cone beam when we think we need to. And it is 30% of the kids from 10 to 16 who come in have some form of degenerative joint disease or condyles that are strange in one way or another. And it has nothing to do with the growth process, and they're in the middle of growth. I just showed a bunch of them on 7, 8, 9-year-olds. So again, I will offend a lot of other people. If you're 7 years old or older and you come in, you get a cone beam before I see you, and then you come into the exam. And I understand about radiation. And I think that's a bunch of bull also.
Yeah, I mean, we dive down all the rabbit holes, and you and I are aligned very closely on a lot of the things we say, so I'm not going to disagree with it. And if anybody else wants, no, but even if we did, I would explain to you why I disagree. You did hit one of the topics was asymmetries related to growth and development, which is a play, but I'm really interested when it comes to I take CBCTs on every patient who walks through the door, and then the dosing is so low. Again, we already know that the argument is moot. There are going to be people who are going to continue that argument. And in Orthopreneurs University in June, we've got Shiva Togyani. She's she's board certified. She's one of the readers for Beam Readers. She's going to basically debunk a lot of the myths that people are hanging on to, and they can continue arguing it if they want to. But, sure. but one of the nicest things I like about having a CBCT, and I will be the first to admit, I am not as diligent as I should be in looking at the joint in 3 dimensions on every patient. I guess I should, but if a kid comes in who's class 1 crowded, face looks good, no asymmetries, I'm not tearing through, somebody comes in with an open anterior bite, of course, that's the other extreme. We immediately look at it to see what's going on. But I could not imagine practicing without my 3D views any longer. I could not imagine looking at the medial lateral poles of a joint and really examining it closely. And again, I'd love to hear your opinion on this. One of the big arguments that's not radiation-based against why people don't want to do CBCTs is it's going to take me too long to read. And number 2, there's so much information there that I don't want to miss something and become legally liable. And I know you're not a CBCT expert, and I know that Dr. Togyani is going to cover that. But can you address real quickly, has it taken you a lot of time when you look at a patient to look through a CBCT? And number 2, are you ever worried about missing something on a CBCT?
Yeah, you're always worried that you might, but the more you do it, the less you miss. And if there's something I have any concern about, they get sent off to beam readers, right?
Exactly.
Look, in terms of doing it, a patient will come in, we'll greet them, they go in, we take photos. My staff member takes a cone beam while they're brought in to talk to my treatment coordinator, who talks to them for 3 minutes. I walk in and do a 5 to 6 minute exam, and it is a checkoff where we go through 72 different things, take 5 or 6 minutes to say, clinically, here's what I'm seeing. You got a little asymmetry in your face. The proportions are good. When you said 4 or 5, the teeth went too deep, blah, blah, blah. Why don't we take a look at your scan just to take a quick view to see what we see? So 11 or 12 minutes into my exam, the patient sits down, we look up at the big screen, and I go through the Panorex, I go through the lateral ceph, the frontal ceph, the TMJs, both frontal and coronal, and the airway. And it's theirs, and it's theirs. I used to just show this is what we're going to do and what we'd like to look at. Since it's theirs, they said, really? I didn't know that, and so we take a look at the Panorex, and which is, that is just such a wrong thing to look at, because it is so screwed up, especially as you get into the center. I just look, is there anagonial notching? And if there's anagonial notching, that is going to be a difficult case, because the muscles have been overriding everything for at least 3, 4, 5, 6 years. So it just tells me how easy, when they're all through, I will go through and take it apart, and just going through all of the breezes, taking each tooth individually to see whether it's in bone or out of bone. And I think it's like 12% of the patients, it's over the last 5 years. I didn't do this before. 12% of the patients who come in already have 4 or more teeth that are not within the cortical plate.
Wow. So
I want to know that before I do anything. Say, they're not here, and, we're going to try our best to get them in the cortical plate. I just could not practice, and I don't want to be surprised by anything, because I've screwed up enough over the years.
Yeah, you and me both. I've got enough screw-ups. I've got more screw-ups in 7.5 years than you have. You've been practicing, what, 9 years now, 10 years?
Yeah, 51 years.
Yeah. So let's talk a little bit about TMD. So there's so many places we could talk about it. I know you teach courses. When is your next course, in-office course on TMD?
We don't have another one set for in-office. It will probably be in early 2023. Okay. The next course where we're talking anything about TMD, I've got a course in Europe, in Rome, which is 2 days of mechanics and 1 day of TMD. Now, maybe, if I don't really do a lot of TMJ courses unless I get requests, and if I get requests, we need, X amount of people to make it financially worthwhile to do it. And
when people talk about systems, by the way, if you can let everybody know, your average case finishes in how much time?
The last thing we did, we just had somebody come in and do a chart audit, take 40 cases and then pick 25 out of those. The average time is 14.3 months and 7.3 visits.
Yeah, so eat your heart out. And that's what generally braces, not aligners, correct?
Oh, yeah. I'll say more. I have never used Invisalign, and I use aligners just very sparingly. And
right, so for anybody
that's just
out
what
there,
I choose.
It's okay. But anybody out there goes, oh, he's, the big buzzwords, KOLs. Here's a guy, braces only, doing high-end ortho, doing proper exams. This is everything. If you rail against modern ortho and all its terribleness, this is a guy treating people in braces in an average of 14 months and 7 visits. So there's a lot to be learned here. This is a very serious man when it comes to systems and policies, and there's a lot to be learned. And like I said, the course we took as Orthopreneurs RD, went to go see him in San Diego. The systems and policies and notes you'll get are insane. But diving back into TMD, when I came over into ortho from restorative and I started talking about, I would see a lot of the times, not all the time, I want to be crystal clear about that, because people's heads, as you know, they could explode when I say what I'm about to say, kind of like Mars Attacks, when Slim Whitman starts singing and their heads start to vibrate and then just explode. When I talk about the fact that if I was visiting a colleague's office one day, somebody I respect a ton, you know what, I'll say his name. There's no reason to, there's nothing embarrassing here. Dr. Maz Moshiri, a friend, somebody I look up to, a mentor. does really exquisite ortho. And I was visiting him one day a few years back, and I was watching his case, and he's not afraid to dive into splints either, right? His father, very, very learned man when it comes to TMD, and Maz is no different. And so I was watching him do a lot of splints, some full of coverage, some pivot splints, some fun stuff, which I call fun, and I know you do too.
Yeah.
And I started noticing, just because I was an outsider looking in, right? Usually in my practice, I don't notice these things, but I was starting to notice that like he had made something like 5 or 6 splints that he was checking on that particular day, who happened to be women in their 40s with 4 bicuspid extractions. It just happened to be, right? And I made an innocuous comment like, wow, that was kind of interesting how all 5 or 6 of these people were women in their 40s with 4 bicuspid extraction cases, and they all had identical symptoms. And the community at large was breaking my door down as if I was Frankenstein's monster. They were going to haul me out, hang me up, tar and feather me to the windmill, and then burn it down along with the laboratory. And I couldn't understand why people were so reflexively angry when I talk about 4 bicuspid extraction and the possible, not definite, but possible implications that taking out bicuspids could have on the neuromuscular envelope of function, on the jaw joint. And people were screaming through the screen and how there's no relationship between extractions. Don't you dare say it. Now, you've got a lot of history in ortho, 51 years. Can you explain to me where this response comes from and why people are so angry about this and why they've ruled out the possibility that the torque in the anterior portion of the teeth, the upper anterior teeth, the torque can play a vital role in how the joint functions long term? Or am I crazy?
All of the above. It truly doesn't have anything to do with extraction or non-extraction. What it has to do with how are we finished. It just so happens, and then non-extraction cases, it's harder to get the torque that you need on the upper 4 anteriors, and because of lots of prescriptions, the canine is tipped in that -8 so that we get immediate function. It is the overcoupling of the anteriors, and you don't need extractions to be overcoupled. So whether it's extraction or non-extraction, extraction has nothing to do with TMD. The improper finish of a case,
right,
not having the anteriors function and having overcoupling so that the neuromuscular response says, I don't like banging on those teeth, and something's going to happen. If you don't have fixed retention, which I do not have, you're going to get relapse. If you do, you're going to get the digastric muscles, the posterior temporal muscles are going to pull the mandible back so that you don't feel that overcoupling. That will lead to eventually TMD or MPD symptoms. So look, we talk about cases, the very famous case. That case was treated beautifully, except it was overcoupled.
Can you refer to that case?
It was the Michigan case where there was a huge lawsuit, and Witzig, the general dentist who was teaching never extract and doing bionators and all of that sort of stuff. Don't extract, expand, do all of this stuff. The case looked beautiful, but if you take a look at there was overcoupling. There was not enough torque in the upper incisors. And in spite of very famous people testifying for the defense, for the orthodontist, they lost. And I don't know what the final settlement was, $900,000 or whatever. Out of that came a white paper from eminent orthodontists that said that occlusion and orthodontics has nothing to do with TMJ problems or TMJ health. I find if you take a look at muscles, ligaments, the hard tissue, and teeth, they're all related. You can't just say, well, they're totally unrelated, unless you say it doesn't matter where the joint is. It can be anywhere. Teeth just meet wherever they want to meet. And I find that's pretty easy to do. Why not just round the teeth up and make them look good? And if you don't care where the joint is, and almost none of these people think about the muscles that the patient come in with headaches, neck aches, etc. It is all about unraveling the upper, in my estimation, the upper body. And if you take a look at the work of Travell and Simons, it will just, in this past weekend, we had a course, and I showed people that a prematurity on a tooth, no matter where it is, and that prematurity hits. And because of that, the first touch to best occlusion moves teeth in one direction. It affects muscles on both sides.
Yep.
And if you do that 2,000 times a day, you are bound to have some problems.
And it induces bruxism. It will
and when somebody tells me that bruxism is you're type A, or you go do yoga, I want to scream. Yoga's good for you, but it's not going to fix your bruxism.
Well, and again, there's the part that I think we have a hard time with. And again, I think the history, Malcolm Meister, who I don't know if you ever met Dr. Meister, Mal Meister, who is one of my mentors, taught at Nova. He's probably, I think he just turned 90 not long ago. Probably one of the smartest men I've ever come across that nobody knows of. Orthodontist who wrote so many great kind of treatises on ortho. He taught us so much about the way things move and causation and correlation and made you think a little bit. And he would sit and we talk. I would have coffee with him because I really valued his understanding of history of ortho. And I would say, why are people so anti this? Why are some people so anti? He goes, Glenn, you don't understand. This goes back to the 1950s and 1960s when there was this argument about X, Y, and Z. He used to show me some great studies, I think from the late 50s, I don't remember the name of the doctors, where they actually did cross-sectional studies on cadavers of the TMD to show that an improperly positioned disc, if recaptured, could gain you or lose you 2 millimeters or 3 millimeters of AP correction. And I said, why do people not learn this today? Why are we not studying these as basic tenets of our education? And he would go through the whole history of why people got all unruffled over it and got angry. It's a fair question is, why every time we bring up pathology or we bring up where joint position should be, so many people scream so loudly about there's no science behind it. It's all garbage. It's all conjecture. Yet in fact, there's literature going back to the 50s and 60s if we want to go look for it.
Well, yeah, there is. And if you take a look at any of the journals early on through the 50s and 60s, there was no real science behind it. It was like something happened in their practices that happened over and over again, or in their schools, and they wrote about it, right?
Like I mean, 78% of 5,000 or whatever number of cases, right? It was case reports.
Yeah. And so you take a look at this stuff, and I think part of it is a reaction because the naphologists of the past were, if you don't do this, you don't know what you're doing. You must push that mandible back. You must do whatever. And so the reaction is, that doesn't seem healthy. I'm not mad at those people. I'm upset that I believe the original one, and I treated so many cases that some of which came back and said, look, I didn't say what I did to you. So, well, we can probably fix that. I think it's like everything is based, and here's some more enemies. It's all about the sagittal. You look at a septic sagittal, you have a sagittal plunge, you corrected class 2. And I don't ever look when I'm talking at the side of somebody's face. I look at them straight on. I need to see a frontal ceph. I need to see the frontal everything. And, we only look at the front on pictures when we say, do we have a wide enough smile? You need to see the front skeletally, muscularly, etc. In terms of, we did a whole prescription just because I couldn't get anything else without doing lots of wire bending. Just in dental correction, I'll say this and I'll shut up and you can go on. You rotate the molar, derotating the upper first molar. That is 3 millimeters of class 2 dental correction. Uprighting the lower first premolar through arch form or through prescription will give you 2+ millimeters of class 2 AP correction because what you wind up getting is this auto rotation. That is 5 millimeters of correction. I don't think you can get more than 2 millimeters of correction by class 2 elastics, but you get 2, that's 7 millimeters of dental class 2 correction just by those 3 things. And yet I see people pulling rubber bands for 8, 9, 10 months and the upper molar isn't rotated. If you rotated the upper molar, you wouldn't have to do that. And almost every treated case, and we had people here this weekend who had orthodontics, some 3 times. And I said, just gently hinge your mandible. Don't push it back. Just gently hinge it until you touch a tooth. It wasn't the upper lingual cusp of the upper second molar. It is almost always the lower first premolars. So I said,
I was waiting.
I said, how many of you are not touching on the lower first premolar? It is an art form problem, and it is a prescription problem. When somebody says 22 degrees or 17 degrees of lingual crown tip is what is perfect, and I say, my God, they're starting to look at each other, right? I can go on for like 22 hours just on what you see over and over and over again. I don't care whose prescription, I don't care whose philosophy. It'll be the lower first premolars, one side or both sides, that are hitting before anything else.
Yeah, and in untreated cases, you will see that second molar very often, right? When you put somebody into CR. Again, to be crystal clear, when I put somebody into CR, so that everybody out there, doesn't go crazy when we talk about this, but you got 2 gnatologists here just having some fun. When I put somebody back into CR, whether they're growing or non-growing, I can let go and say, now go into that position yourself. And they'll repeat it, and they'll repeat it, and they'll repeat it over and over and over again. And some people say, well, I can't get them to CR. Well, you need to deprogram them, right? Which is nothing more than putting something in between the front teeth for 10 minutes or so and letting the nasotrigeminal inhibition reflex kick in and get things to relax. And suddenly you can see where they really sit. And
if you get ethyl chloride spray, so if you do, just hinge until you touch a tooth, and they can't get that. So at the exam, open really wide, get the masseters with ethyl chloride spray, get the temporals with ethyl chloride spray, and anywhere from 10 minutes to 3 days, they'll be able to hit first contact. And then I know, is it really a class 2, or is it a class 2 masquerading as a class 1,
right?
Because they're bringing the mandible forward because that's where the teeth fit best.
Yeah, and again, when I first, way back when, I'm talking like 7 years ago, when I first jumped on Facebook, it's even almost 7.5 years ago. I remember I talked about the fact that, having come from the restorative world, occlusal equilibrations were something that were like every single day. Like every patient we put a crown in, you did an occlusal equilibration. And when someone's hitting properly through a full mouth equilibration, you can literally hear it across the room, not figuratively. If you've done it enough times, like I'm sure you have, like I have.
Called the sound eccentric.
I could turn my head away from them and just listen and go, okay, bite a few times for me. And you can hear, and people go, oh my God. Like it literally sounds like, I can't describe the sound of it, but it sounds like 2 pieces of really hard wood, bonk, 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 like coming together. And so I wrote that I love doing occlusal equilibrations. I love treating eccentric relation. And I took flack. Oh, you'll never continue doing that. And I will agree there are some cases I don't treat the CR. I don't look, because if the patient's repeating in it, I'm okay with it. But occlusal equilibration is one of, again, I would say a deprogrammer should be taught to every ortho resident. The concept of deprogramming should be taught to every ortho resident everywhere. Like every dental student everywhere should learn what a deprogrammer is. We'd get way more referrals to ortho if dentists were using deprogrammers. And number 2, I think we were all taught occlusal equilibrations on day 1 of dental school when we were given a typodont and they said adjust it, and they showed us how. But it's so funny how scared the average orthodontist is. If I said, okay, chair 1, go, full mouth equilibration on that patient right now, they almost freeze up to some extent, because I've had a lot of people ask me, why do you do equilibration so quickly or so easily? I said, I've probably done 1,000 of them. But it's one of those things that you agree that can finish a good case and make it exceptional.
Oh, yeah, absolutely. Especially on adult, they've got fillings, they've got crowns. You get them into, nobody, when the braces are off, nobody finishes without having a prematurity. That's what settling is for, maybe a nathological position, but even people, non-growing kids. And I just explained what we're going to do. It is a microscopic sculpting of the biting surfaces of the teeth. We're not taking anything off the tips. And if it's done correctly, it's probably the hardest thing that any orthodontist or dentist does. That's why it's not done or just zipping and grinding off the tip of a cusp. doesn't work. It's like I had a guy from Texas one time. We were teaching equilibration. He said, I just can't get this. He said, I don't understand it. So it was on an articulator with models. And so we were using at the time Niles Gachet called Madame Butterfly. It was really red typewriter ribbon.
It was the precursor to Accufilm.
Exactly. So you tap, 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 and I said, okay, now you get your little instrument and you just sort of do this, and we do that, and he did that again, and it's up, and he said, damn, I got it. He said, you just chase those little red ants all the way to the top of the hill, and when they get there, you're done. I said, on every tooth.
That is an absolutely brilliant. People are going to make fun of it, but it's totally true.
It's exactly right. You just chase the ants to the top of the hill, and when they get there, you're done.
That's brilliant. And one day, equilibrations for me, occlusal equilibrations are such truly a joy. Like they are so simple and fun, and again, assuming you know what you're doing with them. But I'm one day going to do a video on it, like just show like a real life patient where I do an equilibration from beginning to end, which shouldn't take but 3 to 5 minutes if you kind of do it the right way. But the interesting part, the way I was taught by Jerry Schultz back in the day when I took that course, I tell this to everybody out there. If you're considering to start doing equilibrations and you want to practice, is take a set of models, and they could be stone. Nowadays, they're going to be 3D printed more than likely. And you got to mount them on an articulator. You have to. It doesn't have to be a fully adjustable, but at least something. And paint them with poster paint is what we were taught. Right. Paint them with a red or a yellow or a blue poster paint. So the entire occlusal surface is a different color. Then when you start drilling away, you can look at the end and go, oh, that's how much I took away. So that's as a GP. And if you want to teach this to every one of your GPs, you'll get more referrals, because it was my way of showing them when could you do an occlusal equilibration and when did you need to refer to ortho to fix this problem. Right. And did you learn about the poster paint back in the day?
Oh, yeah. We learned it when I was doing stuff for the lab work. And in the early days, taking the Roth stuff, it was general dentists and orthodontists. And we would be on Stewart articulators, grinding at faucets, and then equilibrating with the paint and taking, I don't even want to look at that stuff anymore, but it's okay. The whole thing is if you have really good occlusal skills, you can take a case that's ordinary and will collapse, and you can make it an absolute beautiful case. And when I tell people, okay, right now when I'm taking your jaw, you're hearing, but you don't hear a nice clap. You hear sort of like a this. When we're through, I'll get your jaw, go up and down, and you will be like,
it's like a nutcracker.
Perfectly.
Yeah, I love
and they
that
said,
sound.
No, that's never happened. My jaw, I said, it will happen.
It will happen.
Anyway,
I always tell them it's like taking a 14-legged stool and making it so all 14 seat at the same time. And again, it's one of those things that I think the biggest challenge we have in dentistry and then ultimately orthodontics is that there were great teaching aids that I learned about that they don't teach in dental school or ortho. Like I'm talking about like 1-hour films that people here would joke about. It's like the DARPA project from Lost. They're like these black and white films from back in the day. But again, if people, I think Bob Lee from Panadent had a whole series.
Yep.
And again, this is where we're going down geekdom, people. So just sit back and enjoy the ride for 3 minutes because he's laughing. But they showed how they made pantographic tracings to start. Then they showed how they averaged out the average condylar inclinations and used, I don't know if you ever saw this video of like, it was like 2 balls that were like routers that they then used to follow the average pantographic tracings of a human being in 3 different paths. And that's what created the Panadent articulator.
Right.
That became the regular lateral and anterior guidance. And if you watched it, you understood why all of this stuff made some sense. And then the occlusal equilibrations, and it was just all like Lundeen out of Florida did a lot of the stuff. And again, I would never in my life want to go through that training ever again. Right?
It's like going through the tweak course.
Yeah.
I wouldn't do the tweak course again, but damn, I know how to bend wire. If I need to bend wire, I can bend it. I know if I need to do a step down, it's because the bracket may be off wrong. It's not just a step down, it's a step down and a torque and a detorque. Because if
Right.
you just step down in the wrong place, so would I ever want to do that again? No. Is it priceless? Absolutely.
Oh yeah. Well, I just it was 3 years of while I was working doing general dentistry, I was also going to University of Washington for this course that they gave once every 5 years, and it was the hardest 3 years of my life. And the funny part was, and this is a great lesson for anybody out there who wants to learn occlusion, because it's easy. Like, it's not that hard, but you have to pay attention and you've got to listen to the people who come beforehand. He started us on a single gold crown. We had to take full models, full records, and do one gold crown and have it equilibrated perfectly. Then he would take us to a 3-unit bridge and then a full mouth reconstruction. And he was trying to say the same principles you use on a single crown are the ones you use on a full mouth reconstruction, which is the same exact technique we use for ortho. And so I'd be a liar if I said that I do this on every one of my cases, but I try to do aesthetic recontouring on every case I finish. And when I look at the occlusion, I try my best, not always, to try to get the bite adjusted. And for anybody out there who wants to say, well, this is too time consuming, if you make any full coverage, fully mutually protected occlusion kind of splints, right? Maxillary splints that just, that simultaneous bilateral contact and anterior contact, as well as light cuspid rise, right? Which is a traditional kind of splint that they teach at Pankey or Dawson. If you learn these, I've taught my team to adjust these so that when I'm working somewhere else, they're getting it close for me. So when I come over, I should be able to look at it and go, boom. And guys and gals, if I can teach my team to do this, you can certainly learn how to do this, right?
I remember in training somebody, after we got out, I remember some orthodontist said, you cannot teach anybody to put torque in a wire. You can't train your staff. And so it was one of my instructors at Harvard who had said that. And I said, excuse me, doctor, how are you going to teach me? If you can't teach,
I like that.
And I don't know, and I'm here for you as long as you want, but I just want to say one thing. On the blogs, especially what you have, every once in a while I say, well, what do you do to differentiate yourself? Since most people don't want to even think about TMJ, you truly want to differentiate yourself, learn TMJ, do it well, get people better. And most of those people, when you're finished, need orthodontics.
Right.
So you still get to do orthodontics, which you love. So take me out. Does everybody do aligners? Yes. Everybody put braces on teeth? Yes. Some people do clear braces? Yes. Are you the only one who does passive? No. Are you the only one who does active, the self-ligating? No. So how have you differentiated yourself?
Right.
You differentiate yourself by doing something that differentiates you. And, I think my wife, who happens to be one of our treatment coordinators, the best ever, she just, we've had her in TMJ 30 years ago. She had an accident. She went to all the people she was supposed to go to, and they said, just sort of live with it. Within a few months, she was totally well. And she doesn't leave me alone. She's in the office. If we get a TMJ patient, she said, they're mine. I mean, our closure rate, I won't even say it because I've said it to a couple of people and I know they don't believe me. That's all bull. That's all bull stuff. It's okay.
You close 104% of the cases you
but when I see people, and this has nothing to do with TMJ, but it does. When they say, we close 50 or 60%, my God, what a waste of time for you. If you're doing that many exams for the patient, and why don't you just, it's possible. And it's not just me. It is possible. But, as one of my mentors told me years and years ago, we all have brain damage. We got brain damage about what we should do, what we shouldn't do. We all have biases. And, I could spend an hour telling you my brain damage, but I can also tell you that I've gotten rid of a lot of brain damage that has helped me both in management and systems and doing TMD and mechanics and that sort of thing.
Yeah. And I just want to add to that. I love your approach towards it. And that's why I said, like, my practice, I love treating adult surgical cases. I love treating cases where there's some internal derangement, perhaps, right? So whether they have a click, I don't care. You know, how many patients have I seen who are an asymmetric, right? You know, they're like a class 2 subdivision or class 2 end-on subdivision, and you look at the CBCT and you see an anterior displaced disc or something on one side. You get them on some elastics or you get them some sort of appliance, and you put all of a sudden they're not as bad as they started with, and they're feeling better and they're happy and they're like, you changed my life. And so I always say, you know, 11 and 12-year-old kids who I finished their case, great. Mom is happy. The kid is like, whatever. I don't even look in the mirror. You help somebody who has some TMD issues. You help somebody who needs surgery. They line up out your door to get started with treatment. Number two, they never, ever argue your fee. Never argue your fee. And they all start treatment.
They do. They absolutely do. And if, you know, again, I just want to back up because sometimes you throw out, you know, cone beams on everybody. If you see somebody who is class 1 one side, class 2 the other, deep bite, and you take a look and you see a little bit of an asymmetry, well, it's, you know, it's because they grew asymmetrically. But one of the things you see that if one condyle is smaller than the other, even if it's not degenerative, it probably is. It's smaller than the other. I see people spending an enormous amount of time class 2 elastics and trying to get midlines on when the shorter side, the condylar side that's smaller, if you want it to be seated, the lower midline is going to be on. It's going to be off. Excuse me. Right. If you see that, I can tell a patient before we start orthodontics, it's going to be off that way. We can get it on, but if you get it on, then the condyle's not seated. Do you want that? If I know that ahead of schedule, I can tell the patient, you know, we're going to get the upper midline right on. And the lower midline more than likely is going to be off to the left, just a little bit, a couple millimeters. That has to be okay with you. Otherwise, you know, we probably shouldn't treat you. So, oh, that's okay. So if you tell them before, they're not going to argue, well, that's off. Yeah, remember we said that? But, you know, people will have class 2 mechanics on one side for 4 months, 6 months, 8 months, and it still doesn't quite get there. So then they start doing IPR, anterior crisscross elastics, class 3s on one side, class 2s on the other, add 6 or 7 months of their treatment, and the patient is not much better than they would have been. Then the condyle is probably not seated.
Interesting. No, again, I could sit with you for days and just pick your brain on things. I'm going to ask you a quick gnathology question on the spot. I want to see, because again, when we talk gnathology, which again, right now, people have tuned out. They don't want to hear anything. It's garbage. There's no science. And I'm fine with that because I know what I know. And I know what my teachers taught me, and I know the literature that we've seen 1,000 times. And I do agree that the dogmatic nature of it did turn a lot of people off to it. But I'm going to ask you a question that the late, great Dr. Jerry Schultz taught me years ago, and there's no literature on this. But as you go home, orthodontist, go look at this. Did you ever learn about what significant wear on a upper lateral incisor might signify? Did you ever hear that one?
Are you asking me or just?
Yeah, I'm asking you. I'm asking you because it was said he made it like a slight little comment one day in class, somewhere during the 3 years. He just made a comment. Oh, by the way, always look for wear on upper lateral incisor edges on one side because that will show you blank. And I was barely even listening, and I went back and started looking, and he was right every time. Do you remember what wear on an upper lateral incisor signifies?
Other than a balancing interference on the opposite side.
Screw you, Roncone. Roncone, I will get you. But it's absolutely true. So I wanted to hear, that was not set up. I heard that years ago.
No, I was worried you're going to ask me something I'm going to look like an idiot.
No, well, we both look like idiots to many people for even talking about this. But for everybody out there, pay attention, because you just heard it from a guy practicing 51 years who's very, very scientific in the way he approaches things. And I learned this from Jerry Schultz, who, again, worked with P.K. Thomas. When you see significant wear on an upper lateral incisor that doesn't seem to make sense, it's not from them posturing forward. There's almost always a balancing interference, right? Contralateral balancing interference, often on the upper second molar is where it's coming from. And the question people might ask is, why do we care about balancing interferences? Because balancing interferences cause significant more muscle firing of the pterygoids, of the temporalis, of the masseter. And as they balance and fight, because remember, posterior contact causes muscles to fire, the ipsilateral side starts fighting. And before you know it, you got a tug of war of the left and the right side trying to seat things properly. And before you know it, you have myofascial pain or you have some sort of dysfunction in the joint. Did I say anything incorrect there, Uncle Ron?
I don't think so. Some of the slides we've developed over the years that people look at that and say, oh my God. But even, for example, if you have an anterior, a lower anterior has prematurity against an upper anterior. And you say, well, you say it's all about muscles. Yeah. If that happens, then the digastric muscle on that side is going to want to pull the mandible back. The SCM on the other side says, no, you don't, and pulls it forward. Now you got stuff on both sides that are active all the time. They're active. And what happens, you get muscle splinting, you get pain. And if the digastric does that over a long period of time, it will, because of the innervation, I always get a sore throat. I'm not sick, but I always have a sore throat. Yeah, that's coming from the digastric. And people look at you and say, what? I don't understand that. So yeah. Anyway,
the next time I have a patient come in who has a ginormous bump in their insertion of their masseter, right? And I say to him, excuse me, I just want to test something real quick. Can you lift your head for a second? And I put my finger, literally at the base of their skull and go, does that ever hurt? And they go, yeah, I take Advil for that all the time. I'm like, this is an occlusal problem. This is, and it shows up every single, so again, I think you and I would agree as we end this conversation, because I feel like I'm in therapy. Like finally, I have somebody who, I'm among my people. Like,
so if you're in therapy, I want to, before you end this, I want to say, how do you feel about that?
I feel like I have I have bilateral simultaneous contact. No, but seriously, it's like, I have these conversations and it doesn't mean just because you're having the conversation that you need to do this in practice all the time. But these are basic tenets of what makes occlusion work, because at the end of the day, we call it the stomatognathous system. There's muscles that are associated around the jaws that's free hanging, right? In 1,000 years, our mandibles will be completely separated from our maxilla for a reason. So the muscles that hold the things together and the ligaments that hold them and the tendons that hold them are what's going to cause problems in the system. And there's a very well-known reason why this occurs. And that's why I will always be forever thankful for the kind of information you share with us, Dr. Uncle. I was going to call you Captain Ron, Uncle Ron. But I really appreciate you. And I sincerely hope that those people listening today took away some great lessons and see this hopefully as a continuation of the journey they're already on, or hopefully the beginning of a new journey. Because let's be honest, the people who taught gnatology and who are the masters of it, it's not a new generation. It's not people coming out of ortho residency now who are the ones who are going to talk about Roth and stuff. And I just sincerely hope that anybody listening here today learns at the school of Roncone and others to sort of keep this information going, because one day, 50 years from now, I sincerely hope it's part of our practice still.
Glenn, thank you. I always appreciate anybody who cares at all about listening to my opinion. That's what it is. So thanks for listening to my opinion.
Well, I appreciate you a ton. And as an honorary member of Orthopreneurs RD.
Thank you, by the way. I still appreciate that.
Yeah, when he just as a quick aside, when he lectured to the group a couple of years ago, we all agreed that he had to become an honorary member of Orthopreneurs RD, and he's been amazing, and I can't wait for the other stuff we're going to learn from you over the years. But thank you for being here today on your Memorial Day. Wishing you many, many more in good health, and thank you for being a part of the podcast.
Thanks what you do to disseminate all the information you do, whether anybody agrees with it or not. It's just a good starting point to listen and give your opinions. Appreciate what you do, Glenn. Thanks.
Well, thank you, Ron. I really do appreciate that.